Hello, everyone, and welcome. I think we're going to get started. As a reminder, you can bring food in here. You're welcome to eat throughout the event, so I encourage you to get some sandwiches and come join us. I'm your moderator today. My name is Bryn Rubenstein. I oversee the Transform Maternity Care program at the Pacific Business Group on Health, which is a non-profit dedicated to innovating and scaling improvements in the maternity care system. I am genuinely honored to be here today moderating a panel of some really distinguished women. This is a topic and an issue that is near and dear to my heart and really drives the passion for the work I do every day. So I'm really excited to be here, and I want to welcome everyone again to the event. And I want to give a thank you to the Tasha Oden French Memorial Foundation for hosting this panel. And I want to remind everyone that this is being live streamed on Tasha's Story Facebook page. So you can encourage friends to follow along on Facebook, and also know that only the panelists are being filmed. If you do have a question but don't want your voice to be recorded, we will be passing out note cards to write down your questions. So just keep an eye out for that. Today we're going to invite Nan to come say a few words, and then we're going to view the documentary, Tasha's Story from Life to Death in 10 Hours. So I would like to welcome Nan Strauss, Director of Policy and Research at Choices for Childbirth, who will be speaking on the issue of maternal mortality in the U.S. and the important role of the birthing community in improving the maternal healthcare system.
Good afternoon, everyone. Thank you, everyone, for coming today. Thanks, Bryn, for the introduction. Thanks, Maddy, for inviting us all here on behalf of the Tasha Oden French Memorial Foundation. I want to just set the stage for the film that we're about to see and give some context, because I think it's important for us to think about why we're here and how important these issues are. No area of healthcare is more in need of reform, or really a revolution, than care around pregnancy and childbirth. And it needs to be at the top of our priority list. You can look at one of any number of metrics that tells us that. You can look at the outcomes that we have. You can look at the number of lives affected. You can consider the economic impact. And I think most importantly, you can think about the opportunity that we have for success. So in terms of outcomes, the maternal child health outcomes in this country, comparatively speaking, are nothing short of abysmal. Right now, the US ranks 46th in the world in terms of maternal mortality, and behind 36 other countries that have lower rates of infant mortality. And that places the US behind every other comparably wealthy country in the world. And it's important not just because of those lives that are touched, but because those are considered bellwether indicators that tell us about the health of the system overall, the maternity care system overall. And each of those deaths indicate a grave problem that goes much deeper. So first, we know that for every woman who dies from complications of pregnancy and birth, there are 100 more who suffer a severe, life-threatening complication, bringing that number to 60,000 women every year in the United States who face a near miss. And that works out to one woman every 10 minutes in our country. And you can think about how many that's been just since you've arrived here today. In addition, both those severe complications of pregnancy and birth and maternal mortality rates are going up. We are one of only 8 countries in the world where maternal mortality is going up and not down. And those figures represent just the average risk for everyone across the country, but we all know that given the health disparities we see in this country, not everybody has the same risk of poor outcomes. Women who live in low-income communities in this country face twice the risk of maternal mortality as women living in higher income communities. But more pervasive and extreme are the racial disparities. For the last 60 years, we have seen no improvement in racial disparities in maternal mortality in the US. It has stayed constant at 3 to 4 times greater risk for African American women. And that's just nationwide. In New York City, where I'm joining you from, the latest statistics found that African American women are 12 times more likely to die than white women from complications of pregnancy and birth, making it one of the worst health disparities that we see in our country across any field, and particularly in childbirth-related care. Also, we can't write off those disparities by saying that they are due to added health risks or due to economics, because you see those racial disparities persisting for women with low-risk pregnancies, healthy pregnancies, for women with chronic conditions, and at all income levels. So education, social support, insurance, access to care, none of those erase the disparities that persist for women who, as you will see here today, have PhDs, rich networks of support and family, and access to the best quality care that you can have. In addition, we can think about the number of lives affected. Of course, 100% of us have been affected by the maternity care system at birth, and in addition, more than 80% of women give birth during their lifetimes. Together, this makes hospitalization for maternal and infant care the most common reason for hospitalization, accounting for between 1 in 4 and 1 in 5 of all hospital discharges. And likewise, that speaks to the financial impact that it would have to make improvements in this area, because both Medicaid and private insurance spend more on maternal and newborn hospital care than for any other type of hospitalization. It has now surpassed $120 billion every year. And about half of those births are covered by Medicaid, which tells us that it's our public dollars at stake. And right now, the return that we are getting on that investment is simply unacceptable. We are paying more for maternity care than any other country in the world, and yet we know, as I was just mentioning, that we rank behind all other wealthy countries in terms of the outcomes that we see. And the other financial factor that works to our benefit in incentivizing change in this area, though of course this isn't our primary reason for calling for change, it's a happy coinciding that in fact we don't need more care. We need care that is offered in a way that is smarter. We need care that is offered when it is needed, in a way that is compassionate and respectful. And in fact, protecting undisturbed physiologic birth and limiting interventions to where they're supported by medical evidence is consistent with achieving better outcomes and not spending more on interventions that not only aren't needed, but they're counterproductive. The real reason that maternity care needs to be considered low-hanging fruit for fixing the system is that there's a high likelihood of success. Nearly half of the deaths and severe complications are considered preventable. And we know what works. We've seen incredible efforts by a lot of the professional associations, by ACOG, ACNM, NACPM, AWAN, sorry, it's a lot of acronyms, but obstetrician, gynecologists, midwives, and obstetric and neonatal nursing associations have been working together like never before to put out evidence-based guidelines to improve care practices. But there's an incredible gap between common practice and evidence-based practice. And that's what we need to see closed. And this gives us the 30,000-foot level view. We know that it would be smart and effective to focus on improving the way that care is provided during pregnancy and birth. But there's another side to these issues, a more intimate side. And I have over the years been privileged to speak with hundreds of women around the country about the care that they have received and how they have experienced this care. And of course, we're going to see the story of Tasha's care later. But I think the point is that while her experience was unique and her value is unique, it is unfortunately not a unique situation, and that is why we're here today. So the single most pervasive theme that I have heard in speaking with women around the country could be described as the need to be treated with respect and to be trusted to make decisions and to be listened to have their concerns truly be responded to. And I just want to give a couple of quotes from women who I've spoken with that I think illustrate this as well as everything else you'll hear today. One woman told me recently, "Once I walked into the hospital, I felt like I didn't have any rights anymore. Too many things happened that were beyond my control. I didn't complain because I ended up healthy with a healthy child. But when I look back, I'm appalled. I felt powerless and like my opinions didn't matter." Another said, "I felt not quite bullied, but definitely not cared for. During the most joyful, beautiful time in your life, you're just another patient on a checklist that the doctor has to get through today." One woman of color told me a few months ago, "After the nurses checked me, there was a doctor and 2 students, and I said, 3's my limit. That's as many people as I'll allow in my vagina in one day. Do not bring another student in here." And the doctor said, "Well, this is a teaching hospital." But I was like, I'm not going to sit here and be your test dummy. It was horrible. And to sum up, one woman described it this way, and I think that she understands the tension between her needs as a patient and the fact that it's not that providers don't mean well, but there's not the system of support in place to help providers consistently provide the best care that they can. And she said, "To a woman, giving birth is the most amazing experience she will ever have. It is so important to feel supported while you're doing this amazing thing. I feel like a lot of doctors today just don't appreciate how important the experience of birth is. Like, they forget because it's their everyday job. I don't think it's their fault. It's the way they were trained and the way hospital structures are set up. But you can see that it causes grief and sadness." And these are all women who ultimately did have healthy births and go home with healthy infants. When we're here, though, it's not enough for us to be asking that women go home alive. It's really a poor reflection on our system if that is the best we can hope for. And of course, that is a bare minimum. But we need to look at the system overall to treat women going through pregnancy and birth with respect, to honor them, to make sure that they have the information that they need to make the best choices for themselves, and to support providers in a system that helps them provide both evidence-based care and compassionate care. Why are we all here today? Ultimately, it's about change. I looked back, when I was preparing for today, I looked back at my notes from a talk that I gave the very first time that I met Maddy. And what struck me was how little had changed. And ultimately, I'd like to be out of a job. I'd like to not be here speaking to you all, because I would like in another 10 years for us all to be able to go home, to move on, to just speak clinician to clinician about improving care, but not to be here as advocates and activists saying we need to fight for women's lives, for treating women respectfully, to end these disparities, because unfortunately that's where we still are today. All of these women deserve better care, and we need to do everything in our power to make it right. That's why I do this work, and I'm sure that's why you're here today. I try to bring to life the voices of women that I meet and let their stories speak and let their voices lead us forward. Thank you.
Thank you, Nan, for that powerful background and context to Tasha's story. So next, I'm excited to introduce to the stage Maddy Oden, the Executive Director of the Tasha Oden French Memorial Foundation.
Welcome to the role of the birthing community in improving U.S. maternity care. This is my daughter, Tasha, and my granddaughter, Allie Mae French. I formed the Tasha Oden French Memorial Foundation in 2003, a nonprofit educational foundation which focuses on the issues of dealing with childbirth and pregnancy. In 2001, my daughter Tasha was 10 days post-dates and went into a well-known hospital in San Francisco Bay Area for a stress test. Her doctor wanted to induce her, however, she did not want to be induced. After hours of holding out, and only when the nurse said, "You don't want to go home with a dead baby, do you?" she finally gave in to their pressures. They induced her with Cytotec or misoprostol, which is contraindicated for labor and delivery. Cytotec was created for ulcers. The process of using an approved drug for another use is called off-label use, and it's totally legal in the US and done all the time. In fact, Cytotec is the standard of care for inducing labor. 10 hours after she was given Cytotec, she died and the baby died. Since 2003, the foundation has been working to have Cytotec, also a major component in RU486, the abortion drug, taken out of the induction toolbox. We petitioned the FDA initially in 2004, asking them to create a medicine guide regarding Cytotec's use for induction. The medicine guide would list all the adverse effects of the drug and procedure and comes with a legal mandate to be displayed in the doctor's offices. We felt that this would encourage women to ask questions regarding the risks, benefits, and alternatives of using Cytotec or misoprostol to induce labor and encourage conversation between their provider. In 2005, the FDA issued an alert regarding Cytotec inductions. This alert can be found on the FDA website and on our website, www.tasha.org. The alert notes several of the severe adverse side effects when given to pregnant women, up to and including death of the mother and death of the child. The original manufacturer of Cytotec or misoprostol, Cyril, sent a letter in August of 2000 to over 200,000 OBGYNs, noting all the horrendous side effects of Cytotec when given to pregnant women specifically, and specifically said, do not give to pregnant women. Copies of the serial letter can be found on the front table after the event, and Claudia Booker will be speaking more about Cytotec after the movie. A few days ago, we filed a petition with the FDA, this time asking for them to conduct a sentinel study for the adverse effects of Cytotec when used to induce labor. The study would enable the FDA to gather research at a greater volume than when depending on the voluntary system of submitting MedWatch forms. You can help support this petition by adding your comments to it on the FDA docket schedule, and a handout at the front table also tells you how to get there through our website. The short spoken word video you're about to see was created by Mildred King, or Marley I. Mildred is a dedicated mother, teacher, musician, and spoken word poet with incredible inner strength and determination for the truth, striving to live a much more natural way every day. I witnessed this in the midst of many physical challenges when she gave birth to a beautifully healthy baby girl, naturally and vaginally, without any drugs or interventions, surrounded by her family, 2 midwives, myself, in my house, all unplanned. Mildred wrote and created the following video, While My Lady Sleeps, after the birth of her daughter, Kyrie, on January 28, 2010. While My Lady Sleeps will be followed by the documentary, Tasha's Story, Life to Death in 10 Hours. Created and written and produced by Carmen Treller-Jones and Jeff Lanzaga, which took them over 2.5 years to make. The documentary is Tasha's story, but it's not about Tasha. Sorry. It's about education. In this case, about the dangers of Cytotec or misoprostol when used to induce labor. But it's really about anything, any drug, any intervention, any procedure that you're asked to use and take without knowing the benefits, risks, and alternatives of that procedure or drug. And it's about being fully informed before giving your consent and knowing you have the right to say no. The documentary is also about maternal mortality and the fact that in the U.S. today, 4 times as many African American women die in childbirth and from childbirth-related causes than white women, which puts the U.S., as Nan said, at 46th in the world in maternal deaths, according to the World Health Organization. We hope you enjoy your lunch and the event. And now, While My Lady Sleeps, which will be followed by Tasha's Story.
So like I said earlier, we have an impressive group of women joining us today to provide insights into ways the birthing community can help improve maternity care outcomes. And building, before we begin and I introduce our panelists, I want to build off of a little of what Nan said and what we heard in the documentary, that there was a Lancet article released last year that compared U.S. maternity care, or compared all of maternity care among high-income countries in the OECD, the Organization for Economic Cooperation and Development. And as you've heard many times today, the U.S. spends the most per birth per capita on birth than any other country among the high-income countries in the OECD. But we have the worst outcomes. And I think something that struck me when I was reading that article is that we are also the only country to not use midwives as often as as other countries to deliver our babies. So I'm thrilled today to have so many midwives on our panel to give us insights into the maternal health crisis we have in the U.S. today. So with that, I'm going to introduce the women on our panel. First, it's Jennie Joseph, is a midwife and founder and executive director of Commonsense Childbirth in Florida. Jennie will discuss the maternal mortality and racial disparities in maternity care. Claudia Booker is a home birth midwife serving the areas of DC, Maryland, and Northern Virginia, and she will discuss the contraindicated use of Cytotec for labor induction. Tina Johnson is the interim director of midwifery practice, education, and global outreach at the American College of Nurse-Midwives, and she will discuss the importance of fully informed consent. And then finally, we have Maddy, who we already introduced, and she's on the panel to discuss any questions related to the Foundation's work and the documentary about Tasha's story.
Thank you very much. I'm grateful to be here. I'm very thankful for Maddy specifically for her bravery and for her generosity in doing this work and sharing her story and the story of her family. I'm a British trained midwife. I got off a plane in 1989. I've been a midwife for 37 of those years, 10 of them in the United Kingdom before I got here. And even though I could sit here and run off a whole bunch of statistics, I won't do that. But I will point out the story because I think it puts a perspective on things. And yes, it was a long time ago, but in the 10 years that I worked in London, in a very busy teaching hospital, with all kinds of women from all over the world, the Commonwealth, and the English themselves, we had one maternal death. And I remember it distinctly, as probably everybody who worked at that hospital did, because we all just shut down. It was so unprecedented. We had never heard of such a thing. We knew about, in developing nations, yes, but we're in London. And this woman had a particular rare clotting disorder, and she died of a hemorrhage. But it was something that went through the entire hospital. It was a general hospital as well as a maternity hospital. The entire cafeteria was abuzz. Everybody was talking about this issue, talking about what happened. Nurses were in tears. Everybody was just falling apart because a woman died having a baby in our hospital. We didn't know what to do. So when I arrived in Orlando in '89, I had that as my background. What I had in my background was that you have some chance of having a cesarean section when you're having a baby if you run into difficulties. But regardless, the next time round, you have another go. And the baby will either come out or it won't. And if it doesn't, you have another C-section. I hadn't got any acronym or terminology for vaginal birth after C-section. I didn't know what a VBAC was when I got here. As a midwife, I didn't know what a VBAC was. I had no clue. But I landed in Orlando, in Florida, in the South, as a black woman, as a midwife, and foolishly thought I'd get a job, which I got over that very quickly, because obviously that wasn't going to happen. But what did happen for me was I had to learn and understand not only the history of midwifery in the United States, and particularly in the Deep South, but also the legacy of the lack of midwifery in the United States. And by that I mean these horrendous and outrageous, egregious statistics that we keep repeating today. Not to mention the story of what we've just witnessed. We've learned about Tasha, her life, and her legacy. So let's be real. When we're talking about maternal mortality, we're talking about dead people. We're talking about dead women. But even more upsetting to me is that we're not talking about nearly dead women. 60,000 in a year in the United States of America. And I really want to champion the cause of the nearly dead women because no one is even thinking about them. They don't exist. Because they get to go home. But let's think about where they're going home from. They're not leaving the postpartum floor with a bunch of flowers in their lap. They're leaving from the ICU. They're leaving from the CCU. They're back in the ER a couple of days after they get home. And no one is dealing with them from any perspective of what's actually going on in plain sight. We have a broken system. And the parts of our system that are broken are the parts that we really need to start talking about. We need to acknowledge what's going on. Because the only way you can survive that system is if you learn how to circumvent it. If you learn how to go around the side, if you learn who's got the back line, who knows the cell phone number, who's friends with. You all know what I'm talking about. We all of us are coming up against a system that is really causing harm and pain and suffering. Institutionalized racism, institutionalized classism, sexism is killing our mothers and our babies. I'm not saying this to be dramatic. I'm saying this because I don't want to be on this panel any more than Maddy wants to be here sharing her story. But we better talk about this because it's a sorry, sorry mess. And I'm going to ask you all, consider, where is the evidence-based outrage?
I'm Claudia Booker, native-born Washingtonian. It's nice to see all of you come out here today. For those of you who haven't had a chance to look at a calendar, today is May Day. It's May 1st. It's a day around the world where people take an opportunity to come together to celebrate what collaboration and commitment to causes that benefit the people, not necessarily the systems nor the government, come together and proclaim and work towards. There are thousands of people today demonstrating across the country. Another day for climate control, another day for rights. And I'm glad that we're all here because I got up this morning and said, oh, I'm going to a May Day demonstration inside. This is nice for me. Thank you. And I get a lunch. I don't have to stand out at Malcolm X Park and spend my day there. Because us being together today is once again showing our commitment for change when it comes to the way we birth in this country, the way all individuals birth in this country. And I thank you very much for coming. It's today where everybody should come out and celebrate this. I wish the newest immigrant to Washington, D.C. Felt the same way. Down the street guy. I'm a home birth midwife. I'm a lawyer. I'm been a doula for 14 years. I'm very happy to be on this panel. I don't know how Maddy does it. It's so hard not to cry. But if she doesn't have to cry, then I don't have to cry either. I want to talk to you about the medication Cytotec, one that has been used around the world for many purposes, some of them showing very good statistics for postpartum hemorrhage and being a lifesaver in countries underdeveloping and redeveloping countries. But the evidence for using Cytotec for the induction of labor, especially advanced maternal age, unfavorable cervix, ruptures of bags of water, fragile women and fragile babies, fragile pregnant individuals, laboring individuals, the statistics and outcomes of those births have not been stellar. We are still struggling with language, the English language in English-speaking countries. The difference between an off-label use and a contraindication use is something that we seem to forget about. Off-label use is using Viagra, not developed for what we use it for now, for erectile dysfunction. Nobody's uterus ruptured for that, so we're pretty much happy with that one. But this drug is not a drug that has been approved in any manner to be used for induction. In fact, the information passed out by the FDA says no company has sent the FDA scientific proof that misoprostol is safe and effective for use in labor. The government's telling us this. The government goes on in its label information to talk about what are the side effects that can come from using Cytotec in labor, including uterine rupture, including fetal distress that will lead to a C-section. It has been indicated in the language that it uses that it is contraindicated, not off-label use, contra, against. Please keep those words clear in your mind. There are care professionals of all denominations who use Cytotec for inductions. But it is not an off-label use. It's a contraindicated use. You're going against. That should give us all pause. If the government says no company has ever presented us information that it can be approved, we should take that into heed when we're looking at that. More importantly, in my line of work, was a study that came out that said when things go bad with Cytotec, there is a racially disproportionate number of women who get cut, who get C-sections. Twice as high number of African American women, women of colors, get cut with a bad reaction to Cytotec during labor than white women do. White women, they're figuring out some way. They're figuring something out. They're making a way when there is no way. African American women are getting cut. And as we know with the statistics that we see in America now, in urban environments, African American women are cut 60%, almost twice as high as white women are cut. And as we all are experiencing now, getting a VBAC is becoming more difficult, not less difficult, even though evidence, especially from the NIH symposium a few years ago, that said a VBAC after one C-section, your chances of uterine rupture are pretty much the same as if you'd never had a C-section before, even though the evidence doesn't support it. We have hospitals and care providers and insurance companies who do not support VBACs. For those of us who work outside of the hospital, state after state after state after state is tying our hands, whether we are CNMs or CPMs, taking away permission for us to do VBACs at home. So that first decision on how you have that first baby determines your childbearing options for the rest of your life. To quote a former immigrant to the city of Washington, say no. Remember Nancy Reagan, you know? Remember, is your brain on drugs? Is your brain not on drugs? You can't wait until you're in labor to make a choice. You can't wait to then. You'll say yes just about anything, you know, in labor. Please do your homework. It's our responsibilities as doulas, as childbirth educators, to have these conversations with our communities before they go into labor. That's not a time to be carrying on a conversation about things that involve life or death. It's time for us birth workers to take the opportunity to sit down and really look at, this is so strange for me, look at ACOG. Wow, this is really strange for me. I'm pulling out ACOG. They have issued 2 opinions recently. Patients' right to say no, N-O, just 2 little letters. No, you have a right to say no. Next, they've issued an opinion about what to do about labor. And it has 6 or 7 really good things that parents should know about. Don't go to the hospital until you've read these. Copy them. I take them with me wherever I go. I take them with me wherever I go, you know. Know what they are. Share them with the staff. Care providers don't always keep up to date on the latest things that have happened. So it's your job to educate them. But don't wait until you get to the hospital when somebody's saying to you, you don't want to go home with a dead baby. And the next time you walk out this room, you're going to have a baby with you. Don't wait till that point in time to educate yourself. Learn to say no. Thank you.
Hi, everybody. Can you hear me? It's working. Okay. Thanks very much, Maddy, for the invitation to come and present with my esteemed colleagues and Nan. I was considering, I've been a midwife since 1999, and I've worked in birth center, hospital settings for many years, and I've been with the American College of Nurse-Midwives for almost 8.5 years now, trying to look at these issues in a different way, to represent the profession in how we talk about what's best and optimal for childbirth and maternity and women's health care. And when I was thinking about the concept of informed consent, you know, that's such an old-fashioned term. And fortunately, as a nation, we have started to figure that out, and so has the world. Informed consent really is a concept that relates to, we sort of think of, you know, what we're consenting to a procedure or an experiment or perhaps some research. And so we're going to sign something after we have heard the risks and benefits. And there's a form oftentimes we see in institutions, and that's what we think of, informed consent. But that does not go anywhere near far enough to really describe the process that's necessary for women and families to make appropriate decisions. Signing a consent form does not mean that the patient is fully informed.
That's right.
Informed consent is also supposed to be rooted in a patient's dignity. People are supposed to have time to figure out and think about the relevant facts. They should not have severe sleep deprivation. They should be prepared. They should be given enough time and not be under stress or duress when they're able to make the best decisions. And we should also consider the principles of medical ethics, autonomy. The patient has the right to refuse or to choose their treatment. Beneficence. The practitioner should act in the best interest of the patient and not cause harm, non-maleficence. And justice. Who gets what treatment? Distribution of scarce health resources, and fairness and equality. And as we've heard, there is a distinct lack of fairness and equality in the treatments and the outcomes that women are receiving in this country. And then we talk about shared decision-making now, and that's really a much more popular term. There's a lot of different definitions. We have lots of foundations and organizations that have embraced this term, including my own organization. We talk about healthcare decisions being made within the shared decision-making process, which is supposed to involve a much more intimate relationship amongst providers and their clients. I know ACOG has statements. All of our organizations have really made statements about what is optimal in shared decision-making, starting to embrace as a nation the concept of, you know, seeking out a woman's participation in decisions, helping people explore and compare treatment options, assessing values and preferences, reaching a decision with the patient, for example, and evaluating a patient's decision. That's what we're supposed to be doing. But we know from the literature that there really are not very good guidelines as to how to do this. Internal medicine specialists have talked about some ways to think about it. Choice talk, being aware of options. Option talk, providing more detailed information. Decision talk, supporting the work of considering preferences and deciding really what is best, and using decision to support tools. And time. Time is critical for success. And these things aren't available in most of the situations that we face on a maternity unit or in childbirth. In fact, we know from research that women are not given adequate information about many procedures that they are inevitably going to face at any time during their childbirth course of care. Labor induction. Many women arrive to a labor induction having never had that discussion prenatally at all. Same with cesarean section, same with many, many other procedures. And now, even as a nation, the National Academy of Medicine put out a paper in January of this year talking about a new concept of patient and family engaged care, where we really are trying to get at better engagement, better decisions, and better processes for a better experience. The patient's experience is really being seen as valuable, in the hopes that we are not going to just have better care, better health, and lower costs, but also now a better culture where it's more inclusive, there's more compassion, there's an improved experience, improved staff retention, reduced burnout and stress for providers, and joy in practice for providers. This is a new framework that is being developed by our national leaders from sort of the 30,000-foot view. And I think it has a lot of merit. But again, its implementation is difficult and challenging, and we find and we know from the literature that it is not happening in maternity care. As we heard from the Lancet series on maternal health, women should be offered care that supports safe physiologic processes of labor with the lowest intervention possible, reduce over-intervention, and support woman-centered care. But how often does that really happen? We know that malpractice liability poses a barrier, particularly in the U.S., and we know that unsatisfactory childbirth experiences happen when quality care promoting well-being with a focus on individual needs is not there, when kindness and respect are missing, and when women are not involved in decision-making about care and procedures, and when we have rushed caregivers who don't communicate effectively or provide continuity of care. Those things break down the system. We know from listening to Mothers 3 studies that many women felt pressured to accept labor induction, for example, and 30% of them did experience medically induced labor. Barriers to communications. Why don't women ask questions? Well, because the provider seemed rushed, or the provider might think I'm being difficult, or the provider wanted different care than I wanted, so I didn't want to challenge the provider. So we know that in order to really change this dynamic that's going on, we need person-led decision-making in maternity care. We need to have people making decisions in situations where they don't feel intimidated, where they have control over the decision-making process, and where they're getting enough information and where they're leading the decision, not agreeing to a decision, not consenting with information, not even shared decision-making necessarily, but person-led care is really optimal. This is a global issue. I know we're talking about the U.S. context here, but there's been a lot of literature written about this topic very recently. We look at how clinicians are perceiving the impact of this culture of fear that we have in childbirth. Clinicians describe work practices within that culture where the political value of fear equals increased anxiety about safety during birth, which justifies a whole range of actions that may or may not even be evidence-based. We know that clinicians feel they're asked to share information in a manner that selectively presents the risks, because the emphasis is on being certain that all possible and potential risks are communicated. So therefore, there's not a real adequate discussion of the has of something. It's just the risks of not doing something. And that's not what we want. That's not optimal. And we know that there has been this shift in focus away from risk and towards health and well-being and the planning of maternity care that we want and we need and what we're calling for here, but that's not being implemented system-wide. And we really have to work hard to change the culture at the ground level, because all of us working at the national level to change these things, all of the wonderful folks we have studying these issues, cannot make that difference at the ground level unless we all take responsibility. So the other thing I wanted to mention is the concept of absolute versus relative risk. And that comes up a lot in maternity care. There's a lot written about it. We have couched the absolute risk as the way we're going to present risks to people. And we say that risks, one risk is much more likely to happen than another. But overall, what is the big picture? Overall, that risk may be very, very small. So for example, if you are taking a look at what happens when a labor induction policy is implemented for anybody after 41 completed weeks, such deaths are extremely rare with any policy. The absolute risk is extremely small. However, there is a difference from when you get past 41 weeks and when you get past 42 weeks, such that it's about a 3 times greater risk. But yet the risk is still less than 1% overall for any bad thing happening to that baby. And so why are we allowing women to use off-label drugs? Why are we not allowing them to use? Why are we just giving them to them without consent at all? There was probably no form signed. Why are we allowing that to happen? And we really need to make a difference and do something about this. We have lots of folks doing studies now about mothers' autonomy in decision-making, coming up with new measured scales and ways to really capture this so that we can hopefully get at the roots of how to have better discussions with women. There's a lot of really interesting research on the topic. And there are like I said, new validated tools for autonomy and decision-making and indicators of respectful maternity care. National and globally, we are moving to change this and to really put the emphasis back on physiologic birth. And we know that midwives are uniquely poised to lead the maternity care community in implementing a more meaningful shared decision-making process. And so I'm grateful to be representing my organization here today and to really make this call out to listen to each other and to listen to women. And I'd like to thank you very much for allowing us to share in this discussion.
So if you have any questions, raise your hand, and we have a couple staff that'll come around with a microphone. Again, if you would prefer not to speak your questions on camera, you can write them down.
Right, but we have plenty of evidence. Right? There's no shortage. And it's great that we continue. We spend more money in gathering that evidence to come back to the same conclusion over and over. How many years? How many dead people? How long do we need to keep beating ourselves over the head with this information and doing more research and having more conferences? My concern is that it's clear and that therefore we need to look at something else. Yes, we know that this has stood for decades. The disparity has not changed in decades. In fact, it's worsening, it's widening. The gap is widening. So how come we're not outraged about that, just that in and of itself? So while we dig deep and we try to figure out what's the reason, the majority of the research, at least that I've looked at, says we need more evidence, we need more research. It could be this, but we need to know more. So let's do another study. That's what's wrong with me. That's perhaps because I'm not American. I don't know. I'm not an academician. I'm a midwife. I'm interested in just getting to the reality. So on the other side, some of the things that Tina just outlined, these are great steps forward, going in the right direction. But while that's going on, the women are still dying. The women are still nearly dying, and the children are without mothers. That doesn't make any sense in my world. So the fact that there isn't a complete body of work that says, we've got enough evidence, now here's some real action, that's where my outrage comes from. I don't know about the rest of you.
I'd like to add, I like numbers. I was raised in a culture before we had legalized lottery, where I had a lot of family members who knew a lot of stuff about numbers, and I've been blessed to still be able to carry on the numbers game in my head. So I like to read studies. I really enjoy it. I took a class in Midwifery College to justify my love of numbers. And my apprentice and I stay up at night sometimes and just do numbers. And I don't know, I've read 200-300 studies that have been done around the world on the use of Cytotec for induction of labor all over the world. Spent a lot of time reading things in India. And the things that have really amazed me on all the studies that I have read, and I mean, this is just what I can carry in one day of the studies, is that there still seem to be, for people who just want to do studies and not necessarily fix anything, the concepts they get caught up with are efficacy. Efficacy, which breaks down into time and money, versus issues of safety. Time and money, safety. What do? How fast can we get this baby out for how cheap can we get this baby out? And many of the studies end with the conclusion, at some point in time, we're going to really sit down and address the issues of safety when we look at these studies, but not today. Not today. The next thing that I notice in the studies is that we're still trying to figure out method of administration. Where is the most efficacy-driven place to put it? Okay? Should I vagina? Should I put it in your, have you swallow it? Should I put it under your tongue, in your drawer, in your jaw, in your anus? I'm just really sorry. If somebody can't tell me why I'm taking it and where I should put it, I have very little trust in what I'm doing with it. Okay? Okay. Put the liquor in a glass and drink it. You know, I don't understand. I don't understand not knowing where I should put it, nor knowing how much of it I should use. Because some people are 25 mics, some people are at 50 mics, some are 50 here, 25 here. So if you don't know how much to use for efficacy and saving money, far less dealing with the issue of safety, and where to put it, I think we need to take it off the shelf and put it back over on the ulcer side of the room. Because the studies that exist for efficacy are showing that you might save some time in labor, but it's like 6 hours. 6 hours, the studies are showing. 4 hours cut off of active labor. 4 hours of cutting out active labor, 6 hours of getting out of birth early, and the chance, the relative risk of the mom and the baby dying. I'm going to take the low, slow road. Those 4 to 6 hours, if there's nothing else wrong, is not that long. Where are we going? It's birth. Take time, slow down. Let's not worry about that. So it's very scary to me when we're looking around saying, let's do some more research. Because, it's like, okay, 3 out of 5, okay, 6 out of 9, okay, 11 out of 13. We got to keep reshuffling the deck because I don't like what I'm seeing. We have enough evidence now to already know we're on the wrong road. Let's look at other ways of getting moms to feel safe so babies come out. A lot about getting a baby out deals with your parasympathetic system, feeling safe and loved and listened and validated to, okay? I see it every day where I work. I see women who come from countries where they have not had great prenatal care before they got here. And I swear I see these little ladies come who were like standing on their toes to even ride at the rides at Six Flags. They're like barely 5 feet tall ladies, okay? And they come in with their community and their friends and a heart that they know they're going to be safe and listened to, at least in their family. And they push out 8, 9-pound babies and they don't tear. Because they've been listened to and they've been loved and they feel safe and the oppression that they deal with in their lives as being immigrants to this country, though we all are, none of us were born here, though we all are, override the system that doesn't address and meet their needs. So part of what we can do to get babies out in a more timely fashion is having our clients and our patients feel safe and listened to. Also looking at other alternative modalities of care to help get us ready for that baby to come out. Acupuncture, chiropractic care, herbs, chanting, belly dancing, centering pregnancy, foot rubs, candlelighting you, good evening at home with your partner, candlelighting you and a good meal. Things that make your body get ready to accept this great journey that it's about to go on can carry us a lot further than having some little white pills standing there trying to figure out, now, where do I put them today?
Thank you, Claudia.
Can I answer real quick? I'm just desperate to answer this question. No. Well,
That's all right. Go ahead.
No. It's just that I really want to thank you for that question, because it does point to, I think, one of the biggest pieces of this, and that is the system. So I don't have any blame and judgment in my heart. It may sound like I do, just forgive me. But if you think about it, it's the system that's wrong, and that's where the righting can be done, the changing can be done. So if you're in a hospital environment, which, like you say, most women are, that's where they're going to have their baby, everybody in the hospital environment is joining in and is complicit with running the system accordingly. It's very strict and stringent how you behave inside of that system. So first of all, I have to acknowledge L&D nurses, because as far as I'm concerned, you all are delivering America. End of discussion. Like, you are the providers for maternity care in this country, right? You do all the work, you do all the thinking, and you take all the blame. Right? And you are always at risk of losing your job at any given minute because you did something, and it all can come back down on you. But then the physicians also, I feel sorry for them because they're in a pickle. They have these parameters, they have to fit in with risk management, they have to fit in with their busy schedules, they have to balance this completely upside down system with its perverse incentives to do it backwards. And they also have to remember they want to keep their job and they don't want to get sued. So they are in a real dilemma as well. That leaves the families who don't know who to turn to. It leaves the doulas either running crazy, being maverick and wild, or trying to kowtow, or trying not to speak for the mother. Or everybody's balancing these crazy things, all of which keep supporting the system that is broken. I do have hope, because I see that when we want to, we can change. So I'm going to give an example. The recent work that March of Dimes has done with the hard stop for not inducing before 39 weeks. Isn't that interesting how quickly that all came? A couple of years later, a few grand rounds, a lot of money. Oh, look, we got it. No more early inductions. Everybody went with, we understand that, we hear it. Many of the hospitals went to a hard stop. Suddenly it was okay. We could manage to make that change because we had this information and this evidence. I'm just going to throw out there, though, that it was interesting, and nothing against March of Dimes. It's an amazing organization. We have the exact same mission, preventing prematurity. But when we were talking about the micro-preemies and the 28-weekers, we couldn't come up with an answer. But the late preterm, it was affecting a different demographic of people in a different way. And all of a sudden, boom, we got an answer. Everybody's on board. We're going to go with this. We're going to make this happen. And I'm grateful. Because any baby lost is a baby that should not have been lost. But when it comes to it, we can make some changes systematically if we feel inclined. Now we're really determined to reduce the cesarean rate. So suddenly VBACs are trendy again. That's another example of we can when we want to. But I want you just to think about, how do we get there? What are the circumstances? Which are the systems that are impacted by other systems? It's all about power. It's about money. And I believe it's about political will.
I have a couple follow-up questions to that, but
I was just going to follow up on, with the places in the world where everything is working the best are the countries where midwifery-led care is the model of care for the vast majority of the women. Yes, where normal birth is being protected and supported from the start, and places like Sweden and the Netherlands, and where, you know, and some would say they also have universal health coverage.
That's right.
So that's another big problem and a big issue in our country, because we really are a continent of a bunch of different nation states, if you will, if you compare us to any other continent our size. And every state does things differently, and the reimbursement systems are terrible, and Medicaid reimbursement rates for midwives are not equitable, and nor for other types of providers. So there's a whole host of complicated issues, but midwifery-led care is demonstrated over and over again in the Lancet and in, you know, every publication you can find, and is perfect type of care model that does lead to adequate person-led decisions and the protecting of that kind of birth environment. And we need to switch to a model that's cost-effective and quality and brings value. And we need to do that because we have an obstetric workforce shortage in this country. There are nearly 50% of U.S. counties that have no obstetrician. 40% of U.S. counties have no midwife or obstetrician. And we have rural areas that have no access to care at all, and yet we want to have barriers to practice in some environments, and yet we don't want to provide anybody in other environments, and we've got to stop doing that. We've got to look at what type of care is going to cover the front lines in the most cost-effective, safe manner, and also at the same time conveniently preserves and promotes physiologic birth. That's part of the answer, and we need to embrace that concept as a nation.
So there's a petition outside for the FDA that Maddy's put together. You know, that's one thing. I wish we knew how to get to the pharmacology company and make them raise the price like they did on epinephrine. That would be my solution. Make that stuff, instead of costing 5 cents a tab, cost $400 a tab, and that would fix it like fast, quick, fast, in a hurry. You know, I think the other thing is basically consumers. You know, we should be a country of consumer-driven economics. We're not anymore. You know, we fall for the hype. You know, we fall for the reality show, whatever. You know, as we can see what's happened in the United States in just the last 103 days. We're not, but we need to start doing that again. The more and more people who say, no, I'm not coming, no, I won't stay. When you go on your tour of the hospital, you know, to see your nice little room and see if they have an aqua doula, okay? Ask some questions. What is your policy for inductions? When you go to look for a OB or prenatal care, have one of the first questions you ask. How do you induce people? When do you induce people? What's your rate of induction? When was the last time you talked to Eugene DeClercq? Is he on your phone? Can I mention your name to him? Does he know you? You know? And if the answers at that point in time are not good, pick up your bag and go somewhere else. If people stop spending their money in places where they're going to be treated badly, people will stop treating you badly. That's what America runs on, consumer-based education. If you find these things out when you were still in the glow and still got the little stick in your bathroom that just turned, start protecting and fighting for this baby then. You got a baby in you. You're somebody's mother. Fight for your child. Fight for your motherhood. Fight for your birth. Don't wait until you get down there when you can't see your shoes no more. Just start asking questions. Consumer-driven change works in this country. It does. Yeah. March of Dimes, it works. Seat belts, it works. Mothers mad against drunk driving worked. Put your trash in the trash can work. We can make those things work. But we have to decide that this is an issue of life and death for everyone. Not just for middle-class white women, but for the sisters. For all childbearing individuals, this is a life and death situation. If you can improve it for our most fragile people, it happens and improves it for everyone. Every little homeless person, child out here who's underweight, hasn't been for prenatal care, can't get a Medicaid card, can't get a ride, nobody to take care of her kids, she can't eat good, her got GBS, her glucose is 140 because she eats yum-yums and ho-hos, okay? And she's going to walk into there and she's not going to know when she got pregnant. And they're going to say, oh, your baby too big, your baby too small, your baby too this. And then they're going to talk about giving her a drug that she doesn't understand that has a potential to kill her and her child. When we can save her, give her informed consent, joint decision-making, say no, back up, talk to the hand, whatever your culture is. When we can do that as consumers, then these things will go away.
And do you have ideas about how to get those messages out to consumers or out to pregnant women?
Yeah, I think it's childbirth educators and doulas.
Well, I think just...
That's right.
Centering pregnancy for those.
We know that the majority of women are inundated with not good information. They're getting like they're being sold something. They're not going to the right places to get the information.
So mine, this is my retirement plan. If you steal this, I will find you. This is my retirement plan. I think we have to do like the Chinese did under Mao. I really do. I think we have to go back to a system that has worked and can work again. And that is us coming off of our up here and going down there to where the people are. Barefoot Chinese doctors changed the whole health system in China. They got up, they went to the villages, they walked, they talked, and they knocked on doors. We can do that. We don't need to go ahead and get a PhD in doulology, okay? Whatever, We don't need to stridate ourselves away from the people who need us. We need to make ourselves palatable to and hearable and translatable to the people who need us. We could very easily come up with, I call them my 5 favorite things. 5 favorite things. Where do people go, especially people who are pregnant, especially people of color? Where do we go? We go to the nail salon. We go to the hairdresser, braid shop, whatever. We go to a place that sells hair. We hang out at the laundromats. Our boyfriends hang out at the barber shops, okay? We need to have an army of people who have little cards made up, laminated, very much similar to the ones that Japigo uses for helping your baby breathe, with pictures and simple words on these are 5 things you need to teach your friends and know about to have a healthy birth. Healthy nutrition, healthy labor, things at the hospital, breastfeeding, depression. 5 things on a card. And we need to go to these places and we need to hold classes, we need to bring foods. How we have walked away from the black church on this issue is beyond my mind to believe. The black church was the center of revolution and change for our communities. And we are not utilizing that as a way to get to our generations of people who may not listen to their doctors and may not have us. The same way, I cannot believe that you couldn't get the churches that are, especially the bigger ones, to have classes where you feed people correctly, where you have juju, and people come in how to cook a good meal. But we have to go to them instead of us waiting for them to come to us. And we have to have something that is culturally specific and easy to read and something that will last a long time. Laminate it, put pictures on it, put some links at the back. Go teach. Go knock on your neighbor's doors. Go to your ANC meetings and teach. We have to take it to them because they are the ones that we have to help save. And when we save them, we save ourselves.
Well, first of all, you know, birth affects 100% of all humans, right? So we have got to stop saying that maternity care is some sort of extra health benefit that is just a throw-on add-on that's going to cost other people like white middle-aged men money, when at one point that guy was a baby and got maternity care and childbirth care. And we can't, you know, people want to look at, this is healthcare for me right now. This is what I'm 50 some years old. This is my demographic. This is what I need. I don't want to pay for those other things. And we have got to get away from that as a country. It's insane. We know that universal health coverage in maternity care is absolutely critical and essential. So at the federal government level, we all have to do our part to put our Congress people on speed dial and call them every single day on the way to and from work when you got a chance or a second, and complain about what's going on. Have your voice heard when it comes to things like health coverage, which is a mess right now. And if we cannot get something done properly in terms of maternity services, we are just really in trouble. The other thing we can do is we can talk, as she said, at our local community level. All of our states do things differently. You know, who knows which state is going to continue benefits and which one isn't? Who's going to roll back the, you know, Obamacare and who's going to stick with it? I mean, it's a mess right now, but that doesn't mean that our voices are lost and that we can't pick up the phone and contact our own state or local legislators and make the issue of importance to them. And then again, we've got to start you know, doing things not only at the churches and in the communities, but we can make change at the hospital level. That girl that you talked about, I took care of that girl at Maryland General Hospital in Baltimore. It's a little small inner city hospital. That woman had a chance of only about a 15 to 18% chance of having a cesarean at our hospital because midwives and physicians ran that show together. And when she walked in the door, she was going to get triaged and delivered by a midwife who she didn't know because she'd never come for care, but it didn't matter because she was going to get treated with physiologic birth and a respectful care in mind, and her outcomes were going to be excellent. Oh, wow, she didn't know who that was that delivered her. It didn't matter. It's about the kind of care that we feel is best and that we're going to work to provide. And guess what? It's more cost effective. And so we've got to give that message as well, that it's much more cost effective to take good care of people when they're in the childbirth continuum than to let them suffer the consequences of not. And it's a message we just have to shout over and over again.
I know we had another question back here.
Hello, can you hear me? I just wanted to also add to this conversation that we need to be open about the effects of systematic generational racism in this country. That's the first thing we need to acknowledge. And I wanted to kind of piggyback on what everybody up front is saying. A big, huge piece is having more providers of color. I believe, especially with underserved African American, there's a huge distrust. So having more providers of color and also having more resources for this population. They're not really dealt a fair share when they start this process of having a baby. And so they need more environments and systems that can help them, non-textbook with more resources.
Ebony, I think too that we should also mention in that the resources and the systems, we need to understand them so we can recognize where they're dysfunctional. Yes, please.
You hear me? I'm loud. So I'm a midwife and I'm in DC and I take care of about a 98% African American Medicaid population. And I'm really proud to say that I feel like we provide some of the best prenatal care in DC for this population. And some of the things that we're providing them include centering pregnancy. We have an IBCLC lactation that does home visits. We have a postpartum care coordinator that does things like help her get back and forth for postpartum appointments. I have a walked right on over to see Miss Carey to kind of talk about how.
And those are really great ideas, and I think that's a great program. I'm a pro sperm. I don't know what the word is. I'm a pro dad. I'm a pro dad person that I think we need to put that back in there too, because when we're looking at, like you're talking about, looking at generations of systematic racism, and centering pregnancy is a wonderful place for women to get in touch with the parasympathetic side and try to relieve some of that stress since we are having such horrible birth outcomes. Somebody's got to turn around here and look at the epigenetic effect on sperm, like we've been looking at what happens with pregnant women. The fathers of our children are suffering in such ways, and behavioral issues like you're looking at are really getting them. And then just the DNA effect of all of us living through centuries of disenfranchisement, oppression, abuse, rape. Black Lives Matter. If the world never thought black boys and black men suffered, the last 10 years have pretty much awakened everyone to that. And we need to be also thinking about ways to do that, because until we can bring men into the healing process with the families, we are still in the place of how do we cure and heal our entire community, I think those things that you are doing are wonderful, but I think at some point in time, someone's going to have to give some thought onto epigenetic impact of racism, oppression, rape, economics, and the prison system on our fathers, so that they can come with some good, healthy, sane sperm, strong sperm here, and have some babies that will have even a better health outcome than we're seeing now.
Thank you for the question. The cause of Tasha's death, I feel, is, like this midwife back here said, the systematic, institutionalized racism.
Yes.
Tasha has all of the, how do you say that, socially accepted variables, however they say that. I mean, she was educated. She was a little bit above the poverty line, not a whole lot, but, and she was educated and she was well-fed. She had prenatal care, but because she was African American and she went in that hospital, regardless of how she responded to these people, I am telling you, her doctor was African American, the doctor on call was African American, all the nurses were white, and they were pressuring her because the doctor actually had to go on vacation, and she wanted the baby to be born. What could she have done? They could have waited. They could have left her alone. They could have sent her home because she was only dilated 2 centimeters. However, this culture doesn't understand waiting. It's free. All the things that Claudia and Tina and Jennie have been talking about in response to your question, Professor, about what can we do outside of the government. I went to a presentation that Bob Moses, who is a very old civil rights activist, was speaking at. And one of the young people said, well, how do we respond to Trump? And he says, don't worry about Trump. Do not even deal with Trump. Trump is a distraction. In regards to solving all the issues that we have to solve, just do it. It was a motto of the Black Panther Party. It worked then. It worked in China. It can work here. Okay.
Yeah.
The reason that Tasha and Zora and so many other women and babies are not here, and even multiple more, what was your percentage? I don't know, 60,000 of the morbidity is gargantuan, and nobody tracks that. Nobody tracks that. Hopefully this Sentinel study will start tracking it. And hopefully the risk managers in the hospitals will get the study and they'll see, oh my God, if all these people realize that, like on TV, they say, if you've taken whatever that mesh thing is, you know, call this lawyer, that's right, and join the class action suit. People, like Claudia was saying, have to get together, they have to do it, but they have to do it from the ground up, because the rest of it is the institutionalized racism in all the institutions is too deep, I think.
There are also a lot of other safer alternatives for labor induction. You can use a little balloon catheter that you can put in for manual it's not a drug. It can be deflated and taken out. There are safer drugs that can be used once the cervix is soft enough, and it, you know, there are just other options that can be much more carefully titrated. Cytotec, as she said, you can't, once it goes in, you cannot get it back. That's one of the, what I think one of the most serious dangers of it. There are other safer things in addition to waiting that can be done if it's really essential that that person is induced. There are other ways.
If it's essential.
If it's essential.
If it's essential.
Which it's usually not.
Yeah.
So we're
back
at
to acupuncture, you know, Lynn.
Right.
Acupuncture.
My baby was born a month after her due date.
Right.
There you go. There you go. And Amish women don't even look at you until you're 43 weeks overdue, or 43 weeks.
But, you know, but that's
post-date.
getting back to the system. You know, we have a system where we have dates. We have your guesstimated due date based on a Eurocentric, I mean, even based on a Eurocentric thing, because, you know, we have to always remember Europe's made up of tribes who just are lighter than me, you know. But it's based on this monolithic view of white people. Okay, and they came up with this monolithic view of white people and came up with this 28-day number times whatever, you know, and everything is built on this fallacy that we're all exactly the same no matter where our genes came from in the world, and therefore we're all expected to act the exact same way. And we are not machines, we are human beings. And so we get hooked into the systematic myth of when your baby has to be born. Some ethnic groups cook fast, some ethnic groups cook slow. You know, and we see that throughout biology in women. Some women in some countries, in Beijing, young girls get their periods at 14 years of age. In Shanghai, they get them at 12 and a half. You know, so there are all kinds of ethnic decisions that set that whole hormonal part of being a childbearing person into your own individual rhythm. And the system is not based on individuals. It's based on a system. This is it. 40, you know, at 42, we got to get the baby out. Yes, there's some risk, but how high is that risk? Is it really an actual risk? You know, yeah, I have a lot better chance of getting bit by a shark standing by that window than I do sitting here, but I ain't gonna get bit by a shark.
Claudia,
And understanding those
it's
things.
just past 2, so I
Okay.
want to be respectful
Yeah.
of everybody's time and make sure we have a moment to close up as well. I know there are many more questions in the audience, so I do hope you will join us for refreshments afterwards. And the panel will be here. The panel will be here till 3, so please bring the questions to the group. And so to close, I would like to. This is a discussion about what the birthing community can do to impact the maternal health system. So what is the one thing you would like this group to take away and go out and do?
I'll charge that each of you consider that you really don't know the system yet, even if you're deeply entrenched in it. I would encourage you to learn the other pieces of the system that perpetuate the way it works, and that the embedded racism, classism, sexism that is in there is causing the harms, and that's where we need to get to work. Yes. And there's a March for Moms coming up on May 14th, Mother's Day, in DC, and we'd really encourage you to come out to that march. We're talking about these issues as well as other things such as paternity and maternity leave, the impact of these disparities on health and so on. So it's a March for Moms. It's marchformoms.org. Have a look and come on out. That's a way to make your voice heard. Thank you. Thank you, Claudia.
Just do me a favor, and every time you see a pregnant individual at the bus, sitting on the bus, whatever, look at her as if she is your sister, as if she is your cousin, as if she's been your best friend forever. And tell her everything you can tell her about how wonderful she is, how empowered she is. Don't let nobody beat her down. Go with what's best. You are somebody's mother. Fight for your child. Tell them. You don't have to know them. Just remember that we are all sisters in birth. Mm-hmm. And every pregnant person is related to us one way or another. And take her on, take him on, take the pregnant person on as your responsibility to make sure that they have a normal physiological birth, even if it's only a 2-minute conversation.
Yeah, I would just encourage everyone to just reconsider the normal physiologic processes of labor and birth. Even women who have many contraindications or conditions that would be considered high risk, those conditions can be managed, and the person is still going to go through a labor and birth. And, you know, we can work as a team to not only manage complications or health concerns or poverty or the effects of, you know, drug use, but at the end of the day, that person's going to come in and they're going to have a birth, and we can help them. We can support spontaneous birth. We can set up systems within our institutions that do that. It is not impossible. You can talk to your risk managers. You can make small cultural changes. You can look at the evidence, and we have a lot of it on our website at birthtools.org that goes through what's the evidence behind walking around in labor and eating and drinking in labor and not using, you know, IV hydration in labor. There's a whole host of studies. You don't have to go out and read them all. Just reconsider it, and reconsider how you can, in any small way, contribute to culture change in the places where you're with women giving birth.
Well, first of all, I'd just like to say one of the things that everybody in the room can do, we have this new FDA petition online. There's information about it out at the front table. You can go online and add your comments to it and take the information on Cytotec. Aside from echoing all the information and summaries that the midwives here have given, I would just like to say that a lot of, I know there's a lot of students in the room, a lot of doulas and midwives, and a lot of information has been given. Some you may know, some you may not know, but the information is out there. And like Claudia says, whenever you see a pregnant woman, whether they are related to you by direct DNA or not, or 6 degrees of separation, or 1 as it really is, or less, you know, give them information, talk to them to whatever your comfort level is. But more than that, just love them up. And let them know that they are somebody, and that they can do this. They were created by God to do this. This is a natural event. Everybody that's here, ever been here, ever gonna be here, it's all done the same way. Coming in and going out. And they can do this. And don't let them go into a hospital room by themselves.
Yes.
Thank you all so much for coming.
Join me in thanking all our panelists. Again, there will be light refreshments out in the foyer area, and our panel should be here for another hour, so we encourage you to stick around and keep the conversation going. Thank you all.